Good afternoon, everybody. I want to welcome you to the SPIA Virtual Alumni Speaker Series, our Alumni Speaker Series, which has continued throughout the course of this pandemic. And the pandemic has thrown curveballs our way throughout, but our own Laura Bain at the School of Public and International Affairs at the University of Georgia has been great at hitting those out of the park. And she's done it again today with, I think, a terrific panel. I think you're going to find this quite interesting, focusing on vaccine rollout. We have a terrific lineup of speakers who will introduce themselves. But first, I wanted to thank our co-sponsors, Verizon and Jonathan Dalrymple, and the SPIA Alumni Board. The Alumni Board has been key in identifying great speakers for us throughout our programs. Our panelists today are super busy, so I'm delighted that they could spend some time with us. Ryan Loke, Shah, Karen Remley, and Tawny Waltz is our moderator. She's the manager of operations and emergency management at Northside Hospital in Gwinnett and Duluth. And I'm going to turn things over to her in just a second, but I wanted to just give you just a couple ground rules. This is a webinar, so we've disabled chat. If you have questions, and we hope you do, put those into the Q&A. And we'll be sending those to our speakers. And with that, I'll turn things over to Tawny.
Hey, hello and welcome everyone to our vaccine rollout webinar. I really want to thank Laura and the SPIA Alumni Board for inviting us here today to have this talk. And so I'm going to start by asking each of our panelists to introduce themselves and then give a brief overview of their role as it relates to the vaccine rollout. So Ryan, do you want to start?
Sure. Thanks, Tawny, and thanks everybody for hopping on the webinar today. My name is Ryan Loke. I'm the Deputy Chief Operating Officer in Governor Kemp's office. I'm also his health policy advisor. And I've been fortunate or unfortunate to kind of see every single angle of COVID in the state's response over the course of the last 14 months or so. Shortly after our first case was identified in early March, I was sent over to our Emergency Management Agency State Operations Center to help kind of build out capacity and manage from there. And then, went to the National Guard base to help build a couple field hospitals, went to the War Congress Center to run a field hospital, went back to public health to help them manage through that, and have since been engaged with public health on a day-to-day and almost hourly basis at this point, helping to accelerate our vaccine rollout. So really excited to talk to you guys today and looking forward to the conversation.
Excellent. Well, welcome and thank you. Deep, do you want to give your introduction?
Sure. Thanks to SPIA for hosting. Pleasure to be in this group. I'm a primary care physician, and I also run Gwinnett Clinic, which is a multi-specialty group in the northeast part of Atlanta. We have about 15 locations in Gwinnett County proper. And so we've been involved with every aspect of managing COVID on a clinical perspective outside the hospital, and also managing the transition into and out of the hospital for our patients, starting with testing, treatment, and now we're one of the few private clinics also participating in vaccination. It's been, I think, an accelerated course in leadership for everyone involved in our executive group, and we've learned a great deal. We're right now still vaccinating. We've transitioned primarily to Moderna, and we've been working very closely with county government as well as the state DPH, which has been a new and overall very positive experience for us, but not without its challenges, pitfalls, and a lot of frustration for patients and community members as we try to explain to them how we can safely do this and the constraints around us. So I'm looking forward to hearing from everybody else's perspective and sharing ours.
Thank you. And last but not least, we have Karen. Will you give your introduction?
Sure. I'm Karen Remley, and I am the director of the National Center on Birth Defects and Developmental Disabilities at the CDC, but also spent 3 months as a deputy incident manager in the response, and for the last couple of months have, along with my day job, been very engaged in making sure that vaccinations for people with disabilities and the homebound is coordinated across the country. So work with all of the various federal agencies, local jurisdictions, and state to understand what's being done and how we can help and assist. And I would say probably the interesting things about me, I was a state health official for 2 governors in Virginia. And during that time period was H1N1. So I sort of got to experience the precursor, the baby the baby pandemic in preparation for this, but a big vaccine rollout program then. And then last spring, right before I came to the CDC, I was a special advisor to the governor in Virginia to help with testing and work with all the people I'd worked with 10 years before to help them kind of gear up for COVID and learn what they could do. So thank you for having me here today.
Well, thank you. Thanks to all of y'all for being here. We'll go on and jump in. As Dean Hour reminded everyone, you can ask questions by posting them in our question and answer box. But we'll go on and start with a couple that I had here. So the first one are, what are the challenges that we in Georgia really faced with this vaccine rollout? What are those primary challenges that were identified?
I'll take first pass at that. I think that's probably in my wheelhouse. You know, the kind of foremost challenge that we face, I think every other state faces as well, is there wasn't a playbook for something like this. You know, we had, like Karen said, you know, H1N1 and a little bit of experience that we could draw from that, but all of the, you know, nationwide mass vaccination planning and pods and state mass vaccination planning were all based on you know, kind of a global influenza outbreak and, you know, a single shot and, you know, having ample supply and not really having to think through, you know, what a 2-dose regimen would look like, what a 2-dose regimen that has to be stored at -80 would look like. And, you know, not being able to understand, you know, what that would look like until probably about 2 months prior to, you know, the Pfizer vaccine getting emergency use authorization. So, you know, the inability to plan effectively and draw from, you know, experience historically, you know, certainly hindered us and I'm sure other states as well. And then, you know, from a rollout perspective, you know, it was cumbersome at the beginning. You know, we were, you know, trying to understand what our immunization tracking systems capabilities were, you know, how providers were going to report in who hadn't had experience using our immunization tracking system. You know, that's clunky and cumbersome in a normal, you know, day, and adding in, you know, providers like Deeps Group and hospitals and public health clinics who, you know, weren't used to giving, you know, vaccines for children, which is what immunization tracking systems were designed for. You know, and educating folks like that was certainly, you know, a challenge as well. And then, you know, ultimately we're in this place right now where, you know, we've got a supply demand imbalance that's starting to occur where we've got more supply, you know, than the demand is out there. And, you know, how we get into communities who are, you know, historically vaccine hesitant, you know, how do we educate folks? How do we get outreach out there and really, you know, make it convenient, if you will, for folks to get vaccinated rather than having kind of these fixed asset mass vaccine sites. So it's been a hell of a learning experience so far, and we're certainly not done, but we're entering in a new phase now of trying to get, you know, vaccine where people are, and not have people come to where the vaccine is. So.
Deep or Karen, do either of y'all want to add anything?
Sure. As a private medical group, we are on a daily basis working with partners in the public space. So, you know, over half of our patients are in some kind of government insurance. We're in communication with our local hospitals, Northside, Gwinnett, Northside, Duluth, Lawrenceville and Duluth campuses, and Eastside are the ones that are through our clinic sites. But we've never worked together so intensely on a daily basis. And so, you know, to draw on Ryan's comments, you know, we had a blueprint from flu. And probably the only thing it really gave us was the stakeholders that were going to be involved with this. But everything else was new and is a novel coronavirus. And this is a novel experience for all of us. There was a lot of question around how do we prioritize vaccine administration above all else? And so in the private sector, what we have to balance in the outpatient clinics and in the hospitals is how do we continue to provide regular care, augment our workforce and able to prioritize this initiative, which is keeping us from doing everything else, and find enough people to participate and vaccinate. So, you know, I'll just say 3 really big challenges that we probably didn't anticipate, even when we knew we were a vaccine allocator and the state had approved us. One is the workforce requirement. It takes an army of people to vaccinate. And there's only so many bodies that you can fit in your buildings, your parking lots, your tents, your stadiums, and also so many qualified individuals. So one is workforce. To its cost, yes, there is money being made available to administer this, but it's still very expensive to run vaccine clinics and vaccine sites. And those monies have not yet been available to the private sector in a significant way. So most of us who are doing it are just subsidizing the cost because we think it's the right thing to do. I think that goes for medical groups and hospitals as well. And 3 is hesitancy. There's been so much distrust from the public about every aspect of this, depending on where they fall politically, religious beliefs, cultural ideas about vaccines and health and testing, that, you know, in a week or two, we're going to have more vaccine than arms who want it. And we're going to be able to focus more on hesitancy. But it's brand new.
Karen, do you have anything to add?
Yeah, so one thing I think it's important for all of us all of you who are on the front lines, to pat yourself on the back, because I don't think any of us, when we were at around the time of Thanksgiving, when disease was, you know, just skyrocketing around the country, weren't sure what was going to happen with vaccinations, would think that by April 13th, over 245 million, since yesterday, COVID vaccines have been distributed and 192 million doses administered. And that's 122 million people who've initiated vaccine and 75 million people fully vaccinated. So you've heard from Deep and Ryan how hard and what the challenges are, but I think it speaks volumes for the people on this call, everybody in every community, state, and locality that have worked so hard in what is truly a novel and historic approach to get people vaccinated around our country. I think we all knew there'd be bumps in the road. Some of the bumps were fully anticipated. Others, you know, were craters that you drove into and didn't know they were going to be there until that happened. But I think the flexibility and resiliency of state and local governments, you heard Ryan talk about how I don't think, you know, 2 years ago, you thought this is how you would be spending an entire year. And to be able to come together, and I think that's what makes public health best, is when we all work together for a common goal. I think Deep talked about, you know, vaccine hesitancy. One of our biggest pushes is vaccinating with confidence. And we look at that as not a marketing campaign or any one thing, but it has to be integrated across the country. So how do we build trust? And one of the ways we build trust, you all heard today, it's making sure we're completely transparent about how the vaccines are developed, how they're manufactured, and how we then follow safety, and are very careful and very methodical about how we get information about vaccine safety and any potential side effects throughout the vaccine program. We know that over 80,000 women of childbearing age who have identified themselves as pregnant have been vaccinated, and there are no safety signals there. But you all have heard about the very, very, very rare, the safety signal for 6 women who had blood clots out of over 7 million doses being administered. If you look at that, that's an incredibly small number, but the CDC and the FDA are fully committed to making sure they understand exactly what is going on and what else we might need to do to monitor. I think a really important part of this, and Deep is critical for this, is empowering healthcare personnel. As we're moving from that time where there's not enough vaccine and a lot of people that want vaccine to people who may be hesitant, we think there are some people who maybe just need to have the conversation with their trusted doctor or nurse, with somebody that they've gone to for other health concerns. They have a strong relationship, and they're going to be able to have that conversation in a different way than you're going to have at a mass vaccination site. Making sure that we're engaging all of those national associations and getting them the information they need at the right time. And then making sure we're engaging communities and individuals, knowing that each community is different, each culture is different. The results are different depending upon where you are in the country. What works in, as I had the state health official in West Virginia tell me, what works in the hollers of West Virginia and Appalachia is not going to work in New York City. So appreciating that and knowing that, and bringing those people to the table. And the last thing the CDC has really worked on, because, you know, it was so glaringly clear in the first months of the pandemic that there were issues of health equity in terms of who was more likely to become sick and become very ill, to make sure we, in the vaccine program, we built in ways to be able to really try and address that, using the federally qualified health centers around the country and targeting vaccine directly to them, using the social vulnerability index and identifying those federally qualified health centers geographically, and making sure they have vaccine. That program's been very successful. So over the next month, that will spread to all of the federally qualified health centers around the country. And I think that once again is an example of meeting people where they get their health care normally. So they're getting their vaccine in a place where they have confidence. And then the federal retail pharmacy program, because so many people do go to pharmacies for medical advice, for problems. They go to get their prescriptions filled. They know their pharmacist again, can have that conversation. And we've seen that be very effective. We've got 21 national partners, and there are over 40,000 sites for people to get vaccinated. So I think we will continue to work with our localities and our states and our medical groups to understand what else we can do to make this be as successful as possible. But I would say, in spite of all the bumps in the road, you all have done an amazing job, just an amazing job. If you look back and think from where we've come. Thank you.
Thank you. So I think one of the things you all hit on is hesitancy and misconceptions with regards to not only the vaccine, but how the vaccine rollout was structured. What are some of the biggest misconceptions you all have encountered, and how can we move forward from those or help people better understand the rollout process and the safety of vaccines?
I'll start with that. I think, I continue to talk to a lot of people about the fact that the mRNA technology that was used for both the Pfizer and the Moderna vaccine is not new, that scientists have been using that and working with it for 10 years. And I think what is hard for people is they think, oh my gosh, that happened so quickly. But it happened so quickly because the entire world of scientists came together and partnered and worked on all the different perspectives at the same time. So where normally it might take 10 years to roll out a vaccine, that's because one company's working on it with one lab. If you think about it, this was an all hands on deck. It was our generation's moonshot to be able to think about how do we get these vaccines safe, ready, and effective. The processes that were went through ahead of time before the EUA was obtained are the same large groups and the same research that we do for any of the vaccines. As a pediatrician, I carefully and know a lot about how the vaccine process occurs, and then how once the Advisory Committee on Immunization Practices approves that vaccine and recommends to the head of the CDC that it be recommended nationally, and then all of the work that's done after for years and years and years to guarantee that all of our vaccines are safe. And I think that, that it was the time compression that I think a lot of people had a lot of issues with, not understanding that it was not political. It was everyone in science coming together to do what they could. And so I think that's what we have to talk to people about and have them think you've got to picture, 100 labs working on this at the same time rather than one. And then you see how that collective work came together very quickly.
Yeah, and to kind of piggyback on Karen's point, you've obviously got, the politics side of vaccine hesitancy, and you've got folks who are just historically going to be a not no but hell no to getting vaccinated. But taking it into the rollout and how we did that versus the other 63 states, territories, and other jurisdictions that had vaccines, that there were 64 different plans that were submitted to the CDC about how to do this. And the previous administration had given states that leeway. The current administration continued on with that, and it led to a lot of questions about why did Georgia prioritize seniors 65 plus when ACIP said 75 plus should be first? Why did New York do essential workers before they did seniors and stuff like that? And so the kind of disjointed state managed approach gave us a lot of flexibility to be able to say, hey, this is how we want to do this. We know our state, we know our people, we know what's going to work hopefully and what's not going to work. But you add in kind of the national scrutiny around vaccine rollouts and comparing what Georgia was doing versus what Texas was doing, New York and California and so on and so forth, that it created a unique messaging challenge for us very early on in the rollout that's continued to this day, and having people second guess decisions about why we chose seniors first and why we chose teachers later and why we didn't do essential workers, so on and so forth. It really all boiled down to, kind of the simple question, which is, what is the purpose of this vaccine? The purpose of this vaccine was to prevent severe hospitalization cases and deaths. It wasn't to get people back into the classroom. It wasn't to get people back into bars. It wasn't to get people back to sporting events. it was to prevent severe cases, hospitalizations, and deaths. And so when you look and take kind of a data-driven approach to it, we knew that more than 2/3 of our deaths in Georgia that had been attributed to COVID had come from seniors. And so if we kind of took that underlying message of what's the purpose of vaccine, and we're able to apply it as the tool to address that purpose, we chose seniors first. We made that decision and caught a lot of hell for it. But you're seeing it pan out now that our cases and deaths attributable to long-term care facilities have absolutely fallen off a cliff. Our cases and deaths attributed to seniors is starting to see a real decline. And so we were able to meet that objective, but getting out there and saying, hey, here's why we're doing this, here's what the purpose is, and why seniors should get vaccinated. Going back to the first question about what were the challenges, that's still a challenge we're dealing with.
I think one of the biggest questions that we get in our clinic when we administer is, did you get it yourself? And did you have your parents get it? And will you have your children receive the vaccine? Now, Karen described sort of this all hands on deck approach for the science and the research to develop vaccines, and Warp Speed pretty much provided funding for that, for anybody who was willing to participate. On the private sector side, we think that this could be augmented overnight, or could have been probably 3 to 4 months ago, by letting everybody participate with vaccine rollout and administration. But because there was limited vaccine supply, that was one issue. We don't have enough to give everybody who wants to participate. And two, how do you fund all this? So there were some constraints there around letting everybody who could participate be a part of that conversation. Our group was fortunate to have the opportunity, but we have resources and we have enough people, and we could spare actual physical sites for this. Also, a very unique thing about administering COVID vaccine is, until everyone's vaccinated in the clinic itself, you have to do it outdoors, and just really unique logistical challenges there. The other point is about this health equity issue, and that what's going to really show up more and more is which populations are getting vaccinated and how quickly are we reaching those that have the lowest vaccination rates. And to Ryan's point, the mortality rate is directly correlated with age. So you're going to be targeting the oldest people in the groups that are the least vaccinated. And that's going to take time and a lot of conversation and a lot of leadership from local community members about bringing those folks in, counseling them, teaching them, and making it readily available and convenient. Whether that's through their primary care doctor, mobile clinics, it's going to be everybody, everything has to be dedicated to this. And that's probably the next phase of this conversation. And I'll just close with one statement about durability of the vaccine. Essentially every medical professional and physician who's involved with this thinks that this is going to be a durable vaccine, and that it's a very good option, regardless of which one you get, to prevent hospitalization and death. As a country, we did not aim for a COVID-0 policy because that is not realistic with this kind of virus. And that messaging was lost somewhere along the way. Just like Ryan said, if you come into our office, we're going to explain to you the goal of this is to prevent you from being hospitalized or dying. And that's a great, great gift. Take it and run.
Okay, thank you all. So to kind of piggyback off what you've said, we've seen with this rollout an intersection, I guess at a minimum, of politics and healthcare, and perhaps even a crash between politics and healthcare. So what have we learned through the vaccine rollout about that intersection? And is there a way to minimize the role of politics within such a rollout moving forward? Or should that be a goal?
Yeah, no, it certainly, should be a goal. I think, when people, look at this vaccine right now, unfortunately, there is a lot of political conversation tied to it, just given, what folks were dealing with, prior to November, what happened in November, and moving forward, people are, attributing, COVID and the challenges with COVID to, the former president, and anything that's happening right now is getting attributed to the current president. And that really shouldn't be the case. As I understand the process, and as Karen explained it, Warp Speed and, the name probably could have been tweaked a little bit, but the folks who really worked on, developing this vaccine at FDA and CDC NIAID and all of those folks in NIH are career public servants who have dedicated their lives to, meeting this moment, and they've met it. They put together, a series of 3 incredibly strong vaccine candidates in record time to meet this moment. And, unfortunately, politics has been drawn into the discussion about it. And so, finding a way to navigate through that, certainly from our angle, has been difficult. Obviously, we're a Republican governor in a conservative state that's changing. And, there are going to be 49.9% of the folks that see when the governor got his vaccine that, that's great. And there's going to be 49.9% of the folks who say, you know what, he just did this for political reasons, but I'm going to get a vaccine anyways. And you've got that middle ground that you've got to find a way to meet. It's like, I'm going to keep harping on, this is the most unique challenge I think that anybody, certainly my generation will ever have to face. But, trying to separate the politics out with the facts about how we got here and how, the international healthcare community really came together, like Karen said, to meet this moment. And, the career servants at FDA and NIH and CDC really, being the face of this. There's a reason that, Dr. Fauci is probably one of the most trusted, people in the country right now, because he found a way to kind of navigate through the politics better than most career civil servants who were put in that position were able to.
One of the most disruptive aspects of COVID is that science itself has become politicized, and there are meaningful differences between the kind of science that's used to develop a vaccine like this and the tests that we use to test for COVID and the statistical modeling, which I think modeling has really created a lot of distrust amongst the public. Modeling is very not scientific in some ways, and that has been mixed up heavily in the perception of how we present these vaccines and their effectiveness and the reason we have them. So from a physician's perspective, we try to really caution patients about looking at statistic modeling. Those are used for very specific purposes, but the media really enjoys statistic models. I mean, they're fun to report on, and they provide a lot of headlines, but they don't have the same kind of scientific basis that a lot of work like vaccine development does. And I think it also speaks to our desire for a data-driven policymaking process with a very strong emphasis on quantitative information. As a physician, I want that, but that's just not always possible in a situation like this. And so I think my request of our government leaders is to caution the public about using the term science when that we're really not using science. We're hypothesizing, we're evaluating, and this is an iterative process, because I think that restores confidence about how we're using science to protect the public and take care of our patients.
And I would just add, the CDC is apolitical. I mean, we're a federal agency. But if you look back over the last year and a half, the previous administration helped lead and fund getting that work done to develop vaccines. The current administration is leading, helping, making sure that people get them fairly and equitably. So I think people bring in politics, but ultimately the system's working. Are there always bumps in the road? Absolutely. But that's what makes our country great, is that we have lots of voices and lots of different people being engaged and having that discussion. We don't have there's only one way. So I see this still as a bumpy success and would want to, really look at it that way. I would add, based on what Deep said, maybe it's because I'm a pediatrician, but I do think in the summer, as the opportunity may become to be able to vaccinate adolescents and then later children, pediatricians have been vaccinating parents for influenza for years. And again, you're back in a situation where you feel safer having the conversation, talking about what's going on, and it may take longer to get more people vaccinated than it did in the these first really fast months, the first quarter of the year. we'll see this huge decline. Then I think it's going to be a longer, slower curve to get more people vaccinated, but we'll have more opportunities to be able to have those conversations with people.
Well, go ahead.
Yeah, there's a big conversation of, is this a marathon or a sprint for vaccination? And the answer is both. The sprints are the mass vaccine sites, a lot of people, a lot of money going into it, but this is a marathon, particularly if boosters are required. You know, we're not going to be running a parallel healthcare system for decades. It's going to ramp down and then it'll be back. So we're ready for that, but we probably need some training and some policy support in order to get everybody on board.
Okay, so speaking of our marathon versus our sprint, that leads perfectly to Dean Hour's question. He says, there's been some discussion of the vaccine supply beginning to outpace demand, and the number of people wanting to be vaccinated may actually top out around 175 million, which means many folks may continue to be on the sidelines, having an opportunity to be vaccinated, but not wanting to be vaccinated. So with that, what are the concerns related to that large unvaccinated population, and how can we overcome that?
So I go back and say, you know, there's concerns there, right? Because you have a nidus for disease and infection that just people, you know, and you can't wait for everybody to be naturally infected because you're going to have a large number of deaths and severe outcomes. And we know the longer a virus circulates, the more likely it is to develop more variants. And we don't know yet what those variants would be like. So I think that's one of the reasons why the CDC is really putting a lot of funding, a lot of communication, a lot of effort in thinking about all of the different places to develop that trust, empower healthcare professionals to have the conversation. So, you know, even if it's your ophthalmologist who's not normally going to talk to you about vaccinations, but you're coming in to see him for your glaucoma or your eye exam, empowering them to talk to you as a trusted provider. And then most importantly, working directly with communities to understand what are the issues, how do you talk about them? I bet everybody on this call who's been vaccinated, as Deep said, the question you get is, did you get the vaccine? Did your children get the vaccine? Did your parents get the vaccine? In our family, we call it a cocoon of love because we want everybody we love to be surrounded by people that are vaccinated. And so, you know, when I talk to friends, and I have friends who say, I think I'm just going to wait it out. And I'll say, you know, just don't wait too long because, you know, here's a vaccine, it will save your life. You know, so you don't want to leave your loved ones alone. You know, and those are the conversations that I think we as a country need to understand will be hard and that we all own a part of that. It can't just be a governor or a president or the head of the CDC or doctors. It has to be all of us having those conversations with everyone we know and care about.
Yeah, and to piggyback on Karen's point, you know, two kind of thoughts with that. You know, the goal kind of moving forward as we hit this supply demand balance is to be able to get supply, you know, where it's convenient for folks, whether it's the federal pharmacy program and the Biden administration's goal to get, you know, everybody to have the opportunity to get vaccinated within 5 miles of their home, or, you know, through their primary care practice or, you know, other pharmacies that are enrolled in that program, and being able to, you know, be with someone you trust, and to be able to have that provider ask the one essential question. The one essential question in maternal child health, you know, is, are you planning to get pregnant in the next 12 months? But the one essential question for COVID vaccine is, you know, have you had the COVID vaccine? If so, or if not, why not? And being able to have that conversation with a trusted partner, we've seen, you know, is incredibly valuable and incredibly important. You know, Karen hit on it earlier. If you go to the FEMA Mercedes-Benz site just down the street right now, you could be vaccinated by, you know, a Fulton County public health nurse who you probably don't know. You could be vaccinated by a retired doctor who's in the Medical Reserve Corps who you probably don't know, or you could be vaccinated by, you know, an Army officer, or, you know, I even met an officer in the Space Force who was a physician who's down here helping us with that. I didn't know the Space Force had physicians yet, but I thought that was kind of cool. But, you know, as we transition to this, you know, provider community-based model and being able to ask that one essential question, there are real logistical problems with the vaccines as they exist right now to be able to do that. You've got, you know, a Pfizer vial that's got 6 shots in it, and once you puncture that Pfizer vial, you know, you've got 6 hours to use it. Or you've got the Moderna vial that has 10 and eventually will have 15. You know, you've got to find, you know, 15 people to get that lined up and be able not to waste doses. Thankfully, we're going to have, you know, 300 million doses of supply by midsummer, which is great. But the last thing that you want to do is waste doses and have one person lined up and then 4 doses or 5 doses suddenly go to waste. And there are storage challenges. There are still conversations that have to be had about, is it appropriate to send 1,170 Pfizer vaccines as they're packaged right now to the Clay County primary care clinic practice and have them sit there, and you can't break down the Pfizer doses into anything less than 1,170. So how you get this into the community is something that I'm looking forward to the federal government figuring out for us and being able to help us with. But it really is transitioning into that community-based provider model here very shortly to have that one essential question with patients in a clinic.
To Dean Hour's question, I think there will be variants, but I'm not worried about them leading to surges. I think we're probably past surges. There might be waves, regional outbreaks, state outbreaks, but we're past that mark where there's a very low probability of a surge. And so we don't worry about that when we go out as a family, that we're going to go somewhere where that's a risk. The other question is, a large part of our population is children. And what are we going to require or not require of them as they've suffered a great deal over the past year with school closures? And that's also had a tremendous negative impact on the workforce and our economy. And I can say in our clinic, the vast majority of our staff are working mothers. And the school closures have really devastated a lot of their professionals' lives. In addition to, what we won't know for a long time, the impact of these on our kids. And again, the science has to really be updated so we can start, in my view, stop looking at kids as vectors, but as children. And how are we going to take care of them safely and give parents the choices that they want and the opportunity to have the conversations that they want to have with pediatricians about whether their kids should or shouldn't be vaccinated. And that's going to be a huge question going into the summer. And it's going to require really strong leadership at every level to make parents and students feel comfortable.
So in talking about the transition from these mass vaccination sites that we're currently seeing to more of a healthcare provider model, what are those triggers that are going to allow us to transfer back, and how do we recognize those?
I think we're seeing it right now. That this is public information now, but there's 320,000 open vaccine appointments at just public health clinics in Georgia right now. For the first time this week, the Mercedes-Benz FEMA site just down the street has walk-up appointment availability because they weren't meeting the appointments that they had. I'm sure Deep's clinic has probably seen a drop-off over the last week or so, and the J&J discussion from yesterday that will carry forward for the next couple of days and hopefully not last too long after that has also kind of helped to create this significant drop-off. And so I think we're at that point where the supply-demand imbalance is more prevalent than it was even midweek last week when we were still seeing some strong appointment demand on our mass sites. But we're at that point right now where we've got to very quickly find a way to transition to that community-based provider model. Getting folks where it's convenient for them to get the vaccine and not have the vaccine be a convenient spot for mass sites or whatever. But the J&J discussion and absolutely the FDA and the CDC made the right call to do that. It creates a new communications challenge for us going forward, because that was the best tool, and it still is the best tool that we have to go into church groups and into civic groups and into communities and say, hey, we've got a vaccine just down the street or just across the parking lot for you. It's one shot. All you got to do is give us some information and you're one and done. Overcoming the significant messaging challenge that was already there, but has been complicated even further, is the next kind of phase of messaging for us, to saying, hey, this 1 in a million circumstance with blood clots and low platelets and severe headaches, and not giving somebody heparin when they present with that, getting that message through and navigating through that while being able to continue to say the J&J vaccine is safe and it's effective. just another unique challenge for public health communicators moving forward. But we are at that point now where the supply-demand imbalance has inverted where it was even from last week. So we've got to start planning for and executing that transition to the community-based model.
I think there are a ton of positives about even the J&J announcement. Number one, it shows that the federal government is monitoring for adverse reaction. The surveillance system works. There's a signal that shows an adverse event. And importantly, the FDA didn't pull it from the market. It's just paused. So sort of unfamiliar to most of us outside of that world, but that's significant. Maybe we adjust who qualifies for this vaccine. We identify the risk group and it's available to everybody else. And it'll be available again soon. Vaccines are our greatest hope to resume normal life. And that's a really important and strong message that needs to be consistently given by those of us in the healthcare community and on the front lines. But to Ryan's point, there is a great model of how to transition this in this sense of how do we reallocate vaccine to places that patients are already coming and individuals are already coming and deal with the financial part on the back end. Most primary care groups want to be a part of this. And I would venture to say a lot of specialty groups, dental offices and others would be happy to, if they knew at least this is going to be financially safe for my practice to do. And that is through the Provider Relief Fund that the Center for Medicare and Medicaid Services rolled out last year. Very effective model, very simple, very straightforward. And another success, I would say, in how we manage this for the healthcare providers themselves to be protected. So the question is going to be, when will the refrigeration and freezing requirements be updated, or how can we change the vaccine? And second, how do we go from multi-dose vials that can only be punctured once to multi-dose vials that can be punctured multiple times, or single-dose vaccines, which is now what we have for flu? I don't think anybody on this panel has an answer to that question. Maybe Karen did.
I can tell you not soon, because it's rapidity versus innovation and how you can measure that. But I think you brought up there's a group right now, a task force outside of the CDC that I spoke for, who is looking at the medical neighborhood writ large, which are all the things you described, and thinking about what are best practices and how do you work. So it may be that the cardiologist might not be vaccinating, but they're having that conversation with their patient and saying, I know this pharmacy, or this doctor who we can sign you up right now for your vaccine. So they've had the conversation, they get them ready. We know that, through Vaccines for Children, the Medicaid program that provides vaccines for childhood vaccinations for half the children in the country, we've got that information. And when vaccine becomes available, those groups of clinicians already have refrigerators for vaccines. They understand a lot about administration. How can we utilize them? I think some of the issues that Ryan and Default talked about is that need for really deep refrigeration with Pfizer and the large size of the vials. And so that's all being talked about. The other thing I always think about as we talk about this transition period, I happen to get my MBA, and it's always interesting for a doctor to think about business, but they always show you for any product, there's a lifetime for the product, and there's the early adopters, the people who bought the Mac computer the first time it came out, and then it kind of matures and everybody wants it. And then there comes people are trying to work to get other reasons for people to want to buy that product, right? And so we're kind of in that maturity stage where the approaches may have to be modified and be different, and we have to just keep working together to think about what works. But I also would go back to, this is not just politics and healthcare, but it's politics, healthcare, and public health. And then it's also civil society and our businesses and people thinking about what are they willing to give up? How long do you want to stay in your house? And as Deep said, what's so important, when do we want our children to be able to have the vibrant lives they deserve and need to be able to turn into, good servants of society? And so I think that's going to push a lot of this as we go forward.
Okay, those are some great answers. So I wanted to ask kind of about your experience in the rollout of things that surprised you. So were there any things that particularly stood out as surprises or creative solutions to problems that we faced with this particular thing? Because you've all said it's very different from kind of the planned rollout that we had for an influenza-like virus with a single dose shot. So what were those things that surprised you, and what were those challenges we overcame?
I'd say two things. One is the unique differences. One of the things with 64 different plans is when you're talking to states and localities, there are 64 different plans. And you couldn't imagine there'd be 64 different ways to do it. But what you do on the Navajo reservation is very different than what you're going to do in New York City or in West Virginia. So it was surprising and also inspirational to see how people really tackled creative ways to get vaccine to people quickly. I think the other thing that I expected, but I hear from a lot of colleagues in the healthcare world, there was such a disconnect between how public health is financed and who public health is, and where your public health department is, what they do, until you need them. And so I think that Ryan's shaking his head, but I think a lot of what I always call prudent, it would be prudent Georgians, probably thought they knew what public health was, but really didn't until all of a sudden they became front and center. And so I think the conversations about how do we fund public health, what does that look like, how important is that for our country, are going to go on for a number of years because of this.
Yeah, Karen, the after action report on all of this is probably going to primarily focus on the public health infrastructure and financing for surveillance systems and immunization tracking systems of the future, and we're already having those conversations, and it's fun now to be able to have that conversation. I wish we'd had the foresight 3.5 years ago to have that, because I think we would have been in a better position as a country to do that. But from a surprising standpoint, the biggest thing that shocked us very early on in vaccine rollout was the difference in the take-up rate between residents of long-term care facilities and the persons working themselves in the long-term care facilities. Long-term care facilities were obviously the hardest hit kind of enterprise of this entire pandemic. Casualties through the roof, and just terrible and heartbreaking loss. You would have thought that the second this life-saving, ultimately life-changing vaccine was made available, that everybody living and working in a long-term care facility would have been lining up down Mitchell Street to get it. And we saw that amongst residents. Anecdotally, what we were told was it was anywhere from 85 to 95% of residents wanted to get the vaccine, and there was a very real reason for that. They were all not able to see their family, not able to have visitors, not able to interact with one another for 10 to 12 months over the course of last year, because of the risk that it presented of having in-person interactions with people coming in from outside facilities. And so we saw some incredible take-up rates amongst residents of long-term care facilities. But conversely, we saw, I don't want to say negligible, but it was poor take-up rates amongst workers in the facilities. And so it was half of physicians wanted to get it, about 40% of nurses, and the janitors, and the food service workers, and the clerical personnel. It was less than 25%. And so that was something that we had to kind of grapple with very early on, is how do we address that, where you're creating this protective bubble for truly the most vulnerable, but you're still exposing them at a time when we didn't know whether or not you could still transmit virus once you've been vaccinated. You're still exposing them to people who weren't getting vaccinated, coming into their homes from outside the community. And so that was fascinating in one part, and it created a real challenge. And we found some creative solutions for that thankfully the government really had nothing to do with. Waffle House actually came into a couple facilities and said, hey, we'll give you a free breakfast if you're a healthcare worker and you're working in one of these facilities and you get your vaccine right now. And that increased take up a little bit. And then eventually, once folks started seeing, hey, Jimmy, who works next to me in the office, got vaccinated, and he didn't, have his microchip grow out of his head, or didn't grow a third arm, they ended up getting vaccinated themselves. And so the take up rate, got there. But that was certainly the most surprising thing to us very early on, was the poor take up rate amongst long-term care facility staff.
Okay, we're almost out of time, so I'm going to go on and ask the last question for everyone. It was submitted by one of our participants today. So if you could go back to the start of the pandemic, what would you tell yourself then that you know now? And also, thank you.
I'll take this one first. I'm in a fortunate situation where I get to work with my family is full of physicians. And while we don't work together in the same physical space, a lot of us work for the same group. And some folks are as old as their 70s and all the way down to their 30s. And we have a very robust management and leadership team. And I think, as Ryan said, likely this is our generation's defining crisis in leadership and management. Trusting your team is essential to getting through this. And my sister has been incredible in leading the vaccine effort. I do a lot of the testing, management counsels the patients, the staff, the nurses, the medical assistants. From feeling so low in the fall and winter to getting a high from being part of the vaccination effort really was possible because we trusted everybody involved with this process. Being a vaccine distributor is a big responsibility, and it requires meticulous attention to detail. And you cannot do it without a strong team. And trusting everybody on your team is essential to being successful in the vaccine rollout. And that extends beyond our practice into trusting our partners at state and county government, and really all the way to the top, to the administration in charge. But I think trust is something that's lacking in a lot of places where we need it right now to improve vaccine uptake. But if you have it, use it to its full advantage.
And, I think if I could go back to the morning of March 2nd, because at about 6 o'clock that night, I got a phone call from Dr. Toomey as I was walking out of my office and said, "Hey, you got to come back in. We've got our first 2 cases." But, being able to go back to that morning and, all of the unknown that surrounded what would have been the next kind of critical first 90 days, and being able to recognize early on that at some point this has to end and there is light at the end of the tunnel. I think, for folks, mental health sake, and for conversations that we're having, amongst the most senior levels of government, and, trying to think through, how do we build ventilators in Georgia? How do we, create N95 masks from people who, had been making napkins before? And, what happens if we run out of hospital beds? And not being able to understand at that time that this has to end at some point, that there is light at the end of the tunnel, was certainly something I think that weighed on probably everybody who had played, any role in all of this, that March, April, and early May felt like there was absolutely no end in sight to this. And so being able to go back on March 2nd and myself, hey, this has got to end at some point, probably would have saved me more than a couple sleepless nights.
Karen, you're muted. Sorry.
Thank you. Sorry. I would just say, I think especially because I have the H1N1 response to look at and look back at, I wished I had really thought about and anticipated more the impact of social media and the degree of misinformation, whether it be, as Deep was talking about, statistics that are used in different ways. We have a society that gets so much information bombarded at them from so many different places now that I think it's sometimes hard when you're evidence-based and moving along to realize how easy it is to be co-opted by other information sources. And we need to kind of proactively think about how do we do a better job of sharing information, of having those conversations, and rather than ignoring that background noise, focusing on it pretty quickly so you understand who and where it's coming from and how you can help better inform those people rather than fight them.
Okay, well, thank you all so much for joining us today and providing that insight into kind of the vaccine rollout from each of your unique perspectives. I'm going to turn it back over to Dean Auer.
Bonnie did a great job of moderating this fabulous program. Just thinking about these last set of comments and thinking about, in particular, Dr. Shah's remarks about trust. I feel deeply gratified for the leadership that you guys have exercised over these many months. And my trust in you is substantial because I know what inspired leaders you are, and your competence is just so manifest. I took away so much from this set of comments, great questions from the audience. Thank you so much for joining us, Karen, Deep, and Ryan. And again, thanks to you again, Tawny. We have other programs that will be coming your way, so keep an eye on email, folks out in the audience there. We'll have programs all the way through May. And with that, I want to thank you again for joining us, and take care and have a good rest of the week.